If you're going to select a rate control treatment strategy, you have several drugs to choose from, and they are in certain classes. For example, beta blockers. In the class of beta blockers, there's lots of choices you could look at. You could look at drugs like propranolol, atenolol, metoprolol, nadolol. There's just many of them, carvedilol, and whatever suits you best and the patient best. There's not a ton of differences in my own experience. What I do try to do is to move a patient to a long-acting beta blocker. If at all possible, it's easier for the patient to take. The other class of drugs, which for me in many cases are actually more effective, are what's called the slow channel blockers. They work by a different mechanism, but they also control the heart rate during AFib. Those are really two drugs, verapamil and diltiazem. I sometimes start at lower doses, and when I find the right dose of those drugs, I will give, again, a long-acting preparation. And third is digitalis, but I would like to warn you not to use digitalis unless you absolutely have to. There are data in the literature that suggest that digitalis in large groups of patients can increase mortality. So if it must be used because there are no alternatives, then you have to use it. But I hardly ever have a patient taking digitalis. Last of all, the concept that you have to use high doses of a drug to get control belies the fact that you can get away with less side effects, and it's good rate control, by using more than one drug. So sometimes I'll use a small dose of a beta blocker and a dose of a slow channel blocker like verapamil, diltiazem, get excellent rhythm control without engaging the side effects that occur with high doses of both drugs.